Hello दोस्तों. In previous lecture video on neoplasia, we have discussed that any nucleated cell type in the body may undergo neoplastic transformation to form a tumor or neoplasm. This transformation involves accumulation of genetic alterations, likely mutations, deletions, gain amplifications, translocations, that generate cells that can escape permanently from normal growth regulatory mechanism. Neoplastic cells grow to form abnormal swelling or tumor masses, except for leukemia, that are neoplasm of circulating cells in blood. But note that swelling or organ enlargement can also result from inflammation, cyst hypertrophy, or hyperplasia. The term neoplasm is synonymous with the medical meaning of the word tumor and is often used in preferences because it is less ambiguous. Cancer is a word used in the public arena that has emotive connotation as it refers to a malignant neoplasm. Now in this video, we will discuss differentiating features between benign and malignant tumor in detail. Benign and malignant tumors usually can be distinguished on the basis of various histologic and anatomic features like rate of growth of tumor, size of the tumor is capsulated or not, secondary changes like hemorrhage and necrosis, neoplastic cells criteria under microscope, local invasion or metastasis present or not. First one important thing is rate of growth. In malignancies, rate of growth will be very high, whereas in benign tumor, rate of growth will be limited or within normal limit. Benign tumor are usually small and malignant tumor are often larger in size. Whenever we are seeing any benign tumor specimen grossly or when we cut down, what we notice? That they are having a capsule around them. Benign tumors are typically well circumscribed and encapsulated. So we can see in this picture tumor mass and their capsule. Now coming to the another important aspect, if they are having a well defined capsule, so what do you think? They will have some invasion to the surrounding area or they will have some metastasis? No. So benign tumors are non-invasive and no metastasis occur. Exception to this is hemangioma. This is a benign tumor, but they often do not have a capsule. They are unencapsulated and they permeate the site in which they arise. Other benign tumor may not have well-defined capsular, leiomyoma, neurofibroma, etc. Question is, why benign tumor are encapsulated? Benign tumor grows slowly and expand by pushing around tissue rather than invading them. This gradual compression leads to hypoxia, which stimulates fibroblast proliferation. Fibroblast produces extracellular matrix like collagen, which forming a fibrous capsule. Example are follicular adenoma of thyroid. Therefore, benign tumors are discrete, they are readily palpable, movable, and they are excisable by surgical excision. Whereas when we are seeing a malignant tumor mass, they are generally poorly circumscribed, infiltrating, and non-encapsulated. Why malignant tumor usually lack a capsule? Malignant tumors grow by infiltrating and destroying surrounding structure. Because the tumor cells invade beyond their apparent boundaries, the body cannot form a clean fibrous capsule around them. However, some malignant tumor may appear partially encapsulated or surrounded by a pseudocapsule. That pseudocapsule is not actually formed from the host tissue. It is formed by the tumor itself. Examples, renal cell carcinoma may be surrounded by a pseudocapsule. Hepatocellular carcinoma can sometimes show a fibrous capsule. However, despite this appearance, tumor cell may extend beyond the capsule. But important exception have to remember, certain malignant tumors may be genuinely well circumscribed, especially in early stages or in specific organs. Examples, follicular carcinoma can be encapsulated and diagnosis depend on demonstrating capsular or vascular invasion. Some low-grade sarcoma may appear relatively circumscribed. This is why in pathology, finding tumor cells penetrating through the capsule is diagnostically crucial in some lesions. Finally, to memorize, benign tumor push and get wrapped, malignant tumor invade and escape the wrap. Secondary changes are degenerative or reactive alterations that commonly occur in malignant tumors because rapid tumor growth often outstrip its blood supply, leading to ischemia, necrosis, and other tissue changes. Secondary changes in malignant tumors include necrosis, hemorrhage, ulceration, infection, cystic degeneration, calcification, fibrosis, that is desmoplasia, and mucoid degeneration. Tumor necrosis is most common secondary changes. Rapidly proliferating tumor cells exceed their vascular supply, resulting in ischemic cell death. Grossly appears as soft yellow-white febrile areas, microscopically shows eosinophilic debris and ghost outline of cells. Tumor hemorrhage occur due to fragile, newly formed tumor vessels rupture easily, may produce intratumoral bleeding or surface ulceration with blood loss. Remarkable hemorrhage seen in choriocarcinoma, renal cell carcinoma, etc. Dystrophic calcification or calcium deposits in necrotic tumor tissue occurs despite normal serum calcium. Common examples are papillary thyroid carcinoma, serous papillary carcinoma. Neoplastic cell can be judged microscopically by features like differentiation and anaplasia. Differentiation is the degree of resemblance of tumor cells to the corresponding normal mature cells, both structurally and functionally. In simple words, differentiation tells us how closely tumor cells look and behave like the normal tissue from which they arise. If we see differentiation in context of benign versus malignant tumors, benign tumors are usually well differentiated, closely resembles normal tissue, maintain normal functions and grow slowly. Example are lipoma. They are composed of benign adipocytes which is resembling their parent tissue, which is resembling the normal adipocytes. And you cannot differentiate microscopically from the normal adipocytes. Only when the tumor is growing and forming a mass that we can appreciate that this is a benign tumor. So look over here. This is a slide of thyroid follicular adenoma. It is a benign tumor and see how much this is resembling the normal thyroid tissue. Whereas on the other hand, we are having malignant tumors which are having a wide range of parenchymal differentiation. Malignant tumors may be well differentiated, moderately differentiated, poorly differentiated, or undifferentiated at all. Lose resemblance to normal cells as malignancy progresses. So the difference between the well differentiated carcinomas and benign tumor is very subtle, means you cannot differentiate with the benign tumors and the well differentiated cancers. The malignant nature of the well differentiated cancer is revealed by the ability to invade and metastasize. Functional capacity often decrease or becomes abnormal. Examples are adenocarcinoma may still form glands if well differentiated, but poorly differentiated tumors may lose glandular architecture. Secondly, the malignant tumor, they can be very poorly differentiated or they can be anaplastic. They have very little or no evidence of differentiation. Okay, and this is also one of the hallmark of malignancy. So in between these two, we are having moderately differentiated carcinomas. Okay, so let us see. In well differentiated tumor, cells closely resemble normal cells. Tissue architecture is preserved and having better prognosis. This is a well differentiated squamous cell carcinoma. See how much they are resembling their normal squamous epithelium. So that is why we are calling them as well differentiated squamous cell carcinoma of the skin. The tumor cells are strikingly similar to the normal squamous epithelial cells with intercellular bridges and nest of keratin pulse. Moderately differentiated has partial resemblance to normal tissue, having intermediate behavior. Now this is moderately differentiated carcinoma. It is an adenocarcinoma. See, these are glands, but it is not like a benign glands or not like a normal glands. It is quite irregular in shape. The nucleus is quite hyperchromatic over here. Okay, so this is a malignant tumor of the colon. See on the left hand side of the image, we are having the normal glands and on the right hand side, they are malignant glands. So the tumor is considered moderately differentiated because some amount of gland formation is still there. This is why we are calling it is as moderately differentiated adenocarcinoma. Poorly differentiated has minimal resemblance and more aggressive behavior. Undifferentiated or anaplastic has no recognizable resemblance, highly malignant and having worse prognosis. Look at this tumor. It is not resembling anything. See how much anaplasia is present here. Okay, some of the tumor nucleus is so big, some of the nucleus is so small. They are having prominent nucleoli. They are hyperchromatic. They have vascular chromatin. They are not in all resembling their parent tissue. So we do not know they are arising from which part of our body. So this type of tumor is called as anaplastic tumor. Clinical importance of differentiation is important because it helps determine tumor grade, biological behavior, aggressiveness, response to therapy, and prognosis. Generally, the less differentiated the tumor, the more aggressive it is. To memorize, the more the tumor remembers its origin, the better the prognosis. Example, squamous cell carcinoma. Well differentiated, prominent keratin formation and intercellular bridges. Poorly differentiated, little keratin, marked pleomorphism. Undifferentiated, origin may be difficult to identify without ISC, immunohistochemistry. Anaplasia is a hallmark feature of malignancy. First, what is anaplasia? Anaplasia means complete loss of differentiation and cellular maturity. Key features are seen only in malignant neoplasm. They are irreversible and indicate aggressive behavior and poor prognosis. The term anaplasia literally means to form backward, implying a reversal of differentiation to a more primitive level. This phrase does not mean that a mature cell actually travel backward through time and become an embryonic cells. Rather, it means that the tumor cells lose the structure and functional characteristic of mature, specialized cells and begin to resemble primitive, undifferentiated cells. In other words, the cells appears to have reverted to a more immature state. In normal development, what happens? Stem cells become immature cells and finally developing mature specialized cell. As cells differentiate, they acquire specialized functions, develop characteristic morphology, produce tissue-specific proteins. In malignant tumors, accumulate genetic and epigenetic abnormalities, disrupt differentiation pathways. Cells lose their mature features and specialized functions. Thus, the sequence appears to go in reverse from mature cells to poorly differentiated cells to undifferentiated cells. This is why anaplasia is described as a reversal of differentiation to a more primitive level. This can be understood by this analogy. Think of a highly trained specialist, such as cardiologist, who loses all specialized skills and behave like an untrained beginners. Similarly, differentiated cells are highly specialized professionals. Anaplastic cells are primitive, unorganized cell lacking specialization. Microscopic features of anaplasia include marked pleomorphism, hyperchromatic nuclei and prominent nucleoli, very high nuclear to cytoplasmic ratio, abnormal mitotic figures, and loss of polarity. So in malignant cells, we will find pleomorphism. So what is pleomorphism? Variable shape and size of cell and nuclei is called as pleomorphism. Cancer cells often display variation in size and shape. In this picture, we can appreciate this. High NC ratio means nuclei are disproportionately larger for the cell. In normal condition, nucleus will be 1 and cytoplasm will be 4 to 6 times larger. But in case of anaplasia, it will become 1:1. So NC ratio is altered. Hyperchromatic is a term pathologists use to describe a nucleus within a cell that appears darker than usual under the microscope. This darker appearance occurs when cells are examined, use a special stain called hematoxylin and eosin. The nucleus, which contains most of the cell genetic material DNA, usually stains blue or purple. If it appears significantly darker than usual, pathologists call this change hyperchromatic. What causes a nucleus to appear hyperchromatic? A nucleus may appear hyperchromatic for several reasons. Abnormal cell in precancerous conditions such as dysplasia often show hyperchromatic nuclei. Many cancer cells are hyperchromatic because they contain abnormal DNA or increased DNA content, making their nuclei darker than usual. But non-cancerous cells can also become hyperchromatic if damaged by inflammation, infection, or trauma. These are called reactive changes. So, hyperchromatic nuclei alone do not confirm a diagnosis, but pathologists use this feature to help identifying abnormal or cancerous cells. Other nuclear changes in anaplasia include prominent nuclei with open nuclear chromatin and irregular nuclear membrane. First, we should know one important thing. Is mitotic figure always a sign of neoplasia? Answer is no. Mitotic figure can be seen in normal, rapidly proliferating tissues like in proliferating endometrium, villi of the intestine, in bone marrow cells. So always remember, it is not the mitotic figure which is sign of neoplasia. Mitotic figure can be grouped into two categories: typical mitotic figures and atypical mitotic figures. So typical mitotic figure in the cell will be having two pole and spindles are hanging them from, so this is called bipolar mitotic figure. So typical mitotic figure is also known as bipolar mitotic figure. Can be seen in normal tissue and also it can be seen in tumor tissue. So we cannot say that typical mitotic figure is always a sign of neoplasia. But when examiner says a typical mitotic figure is always a sign of neoplasia, that will be a true statement. A typical mitotic figure, whenever you find, it will be a neoplastic tissue only. Now look at these cells. In these cells, instead of having two poles, now they are having three or more than three poles. So what we are seeing, a typical mitosis can be tripolar, tetrapolar, or anything. In the given diagram, we can also appreciate many atypical mitotic figures. And another thing in anaplasia is cell polarity will be also lost. Orientation of anaplastic cells is markedly disturbed. Seed or large masses of tumor cell grow in an anarchic, disorganized fashion. Now question is, what is cell polarity? So when you are seeing a tissue and they are epithelium, they have apical surface, a basal surface, rest on the basement membrane, and lateral surface attached to each other. This is called as normal orientation and organization. So normal orientation and organization within an epithelium is called as cell polarity. Polarity is about direction and orientation. When all cells know where up and down are, tissue remain organized. When this directional sense is lost, the tissue becomes disordered, which is a hallmark of dysplasia and malignancy. So cell polarity will be intact in case of benign tumor, whereas cell polarity will be lost in case of malignancies. Given picture, left side glands show normal arrangement or polarity, but on right side gland lining epithelium show loss of polarity. This can be better understood by this analogy. Think of a classroom during a lecture. Normally all students sit in orderly rows facing the teacher. This is like normal epithelial cells, where aligned in the same direction from the basement membrane to the lumen. But if a student leave their seats, form random groups and face different directions, the orderly arrangement is lost. This is exactly what happens in dysplasia and malignant tumors, where cells lose their polarity and tissue architecture becomes chaotic. Microscopic features of anaplasia like marked pleomorphism, hyperchromatic nuclei, very high nuclear to cytoplasmic ratio, abnormal mitotic figures, and loss of polarity can be seen in this diagrammatic representation. Benign tumor grows as cohesive expansile masses that remain localized to their site of origin and lack the capacity to infiltrate, invade, or metastasize to distant site. We can see benign fibroadenoma of the breast grossly. The tan-colored encapsulated small tumor is sharply demarcated from the white breast tissue. Microscopic view of fibroadenoma of the breast showing the fibrous capsule right delimit the tumor from the surrounding tissue and tumor proper. The growth of cancer is accompanied by progressive infiltration, invasion, and destruction of the surrounding tissue. We can see, opposite to benign fibroadenoma and invasive ductal carcinoma of the breast, infiltrating the surrounding breast substance grossly and microscopically. See, this tumor is not well circumscribed. It is quite irregular with irregular margin, and it is permeating or invading into the surrounding tissue. Now, the most characteristic property of malignant tumor which we are going to see is called metastasis. How metastasis defined? It is spread of the tumor to the site which are physically discontinuous with primary tumor. So it is important that is secondary must be physically discontinuous to the primary tumor. Metastasis is considered as sure sign of malignancy, as by definition, benign nuclei do not metastasize. But remember, this statement is not a complete or perfect statement because there are exceptions. So, but there are two exceptions which we need to remember for our exam point of view. What are these exceptions? These are basal cell carcinoma of skin and glioma brain. So these are two exceptions which are malignant, but there is no metastasis or very rare metastasis. Basal cell carcinoma rarely metastasizes because tumor cells are highly dependent on local stromal support and usually cannot survive after dissemination. Gliomas rarely metastasize outside the CNS because they are confined to the unique anatomy and microenvironment of the brain, and patients often die from local intracranial effects before distant spread can occur. The invasiveness of cancer permits them to penetrate into blood vessels, lymphatics, and body cavities, providing the opportunity for spread. Now we will see what are the root of metastasis, or we can say how this cancer will be spreading. So there are three important routes. Number one, it is direct spread from the tumor. Number two, it can be lymphatic spread through the lymph nodes or lymphatics. And third one is through the blood vessels, which is called as hematogenous spread. So these are three types of spread you will see for any metastasis. Fourth route can be considered, which is iatrogenic. How? Via surgical instruments. So whenever we are taking the biopsy of a testicular mass, there is a chance that we might spread that tumor into the vessels. Therefore, remember, biopsy of the testicular mass is always avoided. Alternatively, implantation may occur, for example, by accidental spillage of tumor cells during the course of surgery. But overall, most common route of metastasis is the lymphatics. Coming to the direct spread or transgenomic spread. Direct spread means the tumor cells will fall into some cavities or on some organ, and then they will be occupy that one. So that is the direct spread. Example for this type of spread is seen with mucinous tumor of appendix. When this mucinous cyst will rupture, they will spread over the peritoneum. So peritoneum will be having tumor deposits, and that is why it is called as pseudomyxoma peritonei. Krukenberg tumor is also a classical example of transgenomic or direct spread. Krukenberg tumor refers to a metastatic ovarian tumor. Most commonly arise from gastric adenocarcinoma, but also arise from colon carcinoma, appendix carcinoma, and less commonly breast carcinoma. Histologically, the ovaries contains mucin-filled signet ring cells within a cellular stroma. Lymphatic spread is commonly seen in epithelial tumors. So malignant epithelial tumor are called carcinomas, and carcinomas will be having lymphatic spread usually. The pattern of spread follow the natural route of lymphatic drainage. For example, in breast cancer, if the tumor is present in the upper outer quadrant, it is first going into the axillary lymph node. Secondly, if the tumor is present in inner quadrant, it is first going to involve the infra and supraclavicular nodes. Why is this? Because this is natural pathway of lymphatic drainage. But there are two important exceptions. They are carcinoma, but they will not follow lymphatic spread. They will follow hematogenous spread. These exceptions are renal cell carcinoma and hepatocellular carcinoma. Renal cell carcinoma grow into branches of the renal vein, then into the main renal veins, then into the inferior vena cava in a snake-like manner. They can involve the right side of the heart. Hepatocellular carcinoma, it is spread via the portal vein and the hepatic venule. Sometime in exam asked about sentinel nodes. A sentinel lymph node is defined as the first node in a regional lymphatic basin that receive lymph from the primary tumor. Sentinel node examination used for detecting the spread of breast carcinoma, melanomas, colon carcinoma, etc. Why it is important? Because by doing the sentinel lymph node examination, we can say the tumor has metastasized or not. Because if the sentinel lymph node is not involved, that means at this point of time, the tumor has not metastasized. Sometimes local lymph node may be bypassed because of microscopic metastasis or due to variation in pattern of normal lymphatic drainage. This is called as a skip metastasis. For example, in case of a breast cancer arising in the upper outer quadrant, we will see that the axillary lymph node is not involved, but the other side of body they are showing metastasis. So this might be missed because sometimes the metastasis might be very small. There might be no enlargement of lymph node. Coming to the third pattern of spread, hematogenous. The involved vessels are usually smaller veins as arteries with their thick walls are more resistant to penetration. Hematogenous spread is usually seen in sarcomas or malignant mesenchymal tumor. So hematogenous spread is seen in sarcomas except for the alveolar rhabdomyosarcoma. So this alveolar rhabdomyosarcoma will follow lymphatic spread. Apart from this one, more name we have to remember where we will find lymphatic spread, that is the synovial sarcoma. So these are two sarcomas where you will find lymphatic spread. These points should be also remembered for metastasis that organ commonly involved by hematogenous metastasis are liver, lung, bone and brain. Liver and the lungs are frequently involved by the hematogenous dissemination because all portal area drainage flow into the liver and all inferior and superior vena cava blood flow into the lungs. So because the liver and lungs is a site of venous drainage, that is why metastasis is very common in the liver and the lungs. Bone is a site favored by hematogenous metastasis from 5 carcinomas: lung, breast, kidney, thyroid and prostate. Remember, you will never see a metastasis or secondary deposits in the skeletal muscle and the spleen. They are rarely site of secondary deposits. Metastases are frequently multiple, whereas primary tumors arise in the affected organs are usually solitary. Lastly, in this video, in context with neoplasia or anaplasia, certain terminology like dysplasia or metaplasia must be understood. Question is, what is dysplasia? Is it completely reversible or partially reversible or irreversible? When we will give stimulus to the cells, they will having alterations, and when we remove the stimulus, they will come back to the normal state, but there will be some loss of physiology and morphology of the cell. Dysplasia is not a cellular adaptation, but considered as partially reversible condition, and in which NC ratio will be altered and cell polarity will be lost. So in exam, we asked partially reversible condition with high NC ratio and altered cell polarity. Most likely answer is dysplasia. Dysplasia may be a precursor to malignant transformation. Now look at this diagram. In this diagram, when you will see the dysplastic cells, they are disorganized, so orientation and organization has been lost. They are not parallel. Now they are random or haphazardly arranged cells. The extent to which the tumor histologically resembles its cells or tissue of origin determines the tumor grade. So with regard to our cervix, dysplasia is quite well understood. First, see the normal tissue. So there is an orderly maturation of the cells. But if you see over here, in this case, the lower 1/3, the epithelium is dysplastic. So there is a mild dysplasia. See how there is no orderly maturation in the lower 1/3. And the cells in the lower 1/3, they are basal-white and hyperchromatic. Now see, this is the case of a moderate dysplasia. More than lower 1/3 but less than 2/3 is involved. So when more than lower 1/3 but less than 2/3 part of the epithelium involved, it is called as moderate dysplasia. Again, these cells are basal-like, they are small and hyperchromatic, and they are having a disorderly maturation. And when such kind of maturation, if you see involving more than 2/3 of the epithelium, it is called the severe dysplasia. Okay, so I hope you understand what dysplasia is. In this diagram, what you are noticing, that dysplasia is involving entire thickness of the epithelium, and here basement membrane is not ruptured but normal. The term carcinoma in situ refers to an epithelial neoplasm exhibiting all the cellular features associated with malignancy, but which has not yet invaded through the epithelial basement membrane, separating it from potential routes of metastasis, blood vessels, and lymphatics. It is seen in the skin, breast, bladder, and uterine cervix. Next question is, what is the difference between carcinoma in situ and invasive carcinoma? In invasive carcinoma, tumor cells, they will be infiltrating into the underlying stroma. So when we are seeing invasive carcinoma, there will be rupture of the basement membrane and tumor cells will be infiltrating into the underlying stroma. So lastly, we will discuss that what is metaplasia. Metaplasia is a reversible substitution of one mature differentiated cell type by another mature differentiated cell type, better able to withstand a particular stress. Unfortunately, the metaplastic epithelium is irreversible, but it is quite prone to malignant transformation. Key feature of metaplasia are that it is adaptive and protective response and reversible if the stimulus is removed. Cells remain mature and differentiated but may predispose to dysplasia if the insult persists. Example includes squamous metaplasia of bronchial epithelium in smokers, Barrett's esophagus where squamous epithelium replaced by intestinal type columnar epithelium, and squamous metaplasia in cervical transformation zone. So let us see, this is a basic diagram of the esophagus. And this is our stratified squamous epithelium which is lining the esophagus, and see the lower end of esophagus. Now there is a metaplasia. The squamous epithelium now change into the intestinal epithelium. Okay, and this is what we see in case of Barrett's esophagus. A characteristic feature of any tumor is the tumor progression. Tumor evolves slowly, so initially they will be having normal tissue, and from the normal tissue they will be having so many spontaneous mutations, and after spontaneous mutation there will be cellular changes, and finally they will be converted into tumor mass. So it will be a multi-step process. What do you mean by tumor progression? So tumor progression is not a movement of the tumor from one organ to another organ. Tumor progression means they are normal, then there is a mutation, metaplasia, dysplasia, and then anaplasia, which is called as tumor. When we are seeing any normal tissue, there will be two types of mutations lead to this sequence, passenger and driver. What is the difference between passenger and driver mutations? Initially, when mutation will happen, the morphology of cell will be still normal, or we can say phenotypically normal. So when mutation is giving a phenotypically normal cells, that will be called as passenger mutations. They are passive. Driver mutations, they are driving cells to the malignant phenotype. So the mutations which are converting cells to the malignant phenotype, this is called as driver's mutation. Initial mutations, they will intact normal, but later on with successive or progressive mutations, they will be converted into driver mutations, which will be giving rise to malignant phenotype or a given cell, which will be considered as a tumor cell. So this is the tumor progression. Usual progression sequence are chronic irritation lead to metaplasia in long term or stimulus persistent. Dysplasia occurs, further lead to carcinoma in situ, and ultimately invasive carcinoma develop, which show anaplasia. Metaplasia versus dysplasia versus anaplasia. These three terms describe different level of abnormal cellular changes often discussed in the context of chronic irritation and cancer development. In this table, comparative study of metaplasia, dysplasia and anaplasia is given. If you look at the difference between metaplasia, dysplasia and anaplasia, reversibility is an important criteria. Metaplasia is reversible, dysplasia is partially reversible or only in early stages, whereas anaplasia is always irreversible condition. If you look at the cell differentiation, it is maintained in metaplasia, it is low grade in dysplasia, and it is high grade in anaplasia. So the nuclear cytoplasmic ratio is normal in metaplasia, whereas it is increased in dysplasia and anaplasia. Hyperchromasia, if you see, is absent in metaplasia but present in dysplasia and anaplasia. The polarity of the cell is normal in metaplasia, but it is lost both in dysplasia as well as in anaplasia. Mitosis is minimal or absent in metaplasia. It is mildly increased in dysplasia, but they are of typical type or normal configuration. Whereas in anaplasia, they are markedly increased and they are of atypical configuration. So if you see over here that although dysplasia may be a precursor to malignant transformation, it does not always progress to cancer. Just remember this fact. And with removal of the inciting cause, even moderately severe dysplasia may be completely reversible. So we can say that metaplastic epithelium have less but certain amount of chances of developing dysplasia and then cancer. So metaplasia means protective change from one mature cell type to another. Dysplasia, disordered premalignant growth with atypia. Anaplasia, complete loss of differentiation, characteristic of aggressive malignancy. It can also be understood by simple analogy. Imagine a school. Metaplasia, a student from one class are reassigned to another class to better handle difficult subjects. Dysplasia, a student become disorganized and stop following classroom rules. Anaplasia, a student lose all discipline and behave chaotically, causing major disruption. So that brings us to the end of our discussion. Thank you so much for watching this video. If you found it helpful, please like, share and subscribe to the channel for more informative medical content. See you in the next video. Till then, stay healthy and stay curious.